one of our speakers today, and he'll be talking about Alaska's most important infrastructure, that is improving the health and well-being of families with young children. So Matt, who has an MD and a PhD, moved to Alaska in 2005 to become a pediatric hospitalist at the Alaska Native Medical Center, or ANAC. Today, in addition to his clinical work, he serves as ANAC's Medical Director of Maternal Child Health Services, where he focuses on strategic planning and development of services to improve the health and wellness of Alaska Native women and children. He's also a member of the Board of Directors for Beans Cafe, the Children's Lunchbox, an organization dedicated to fighting hunger for all people in Anchorage, Alaska. Finally, Matt is on the board of the All-Alaska Pediatric Partnership, a 501c3 organization that's dedicated to improving the health and wellness of the next generation of Alaska families. The second person who is on our panel is, and you know, I think I learned about you, Jared, Dr. Jared Parrish from Sarah Yoder, and I really appreciate that. And your talk will be addressing ACEs in Alaska and using data to inform practice. Dr. Parrish has his doctorate in epidemiology from the University of North Carolina at Chapel Hill, and he's currently senior maternal and child health epidemiologist at the Alaska Division of Public Health. He also serves on multiple local and national committees, co-chairs the Alaska Statewide Violence and Injury Prevention Partnership, holds an adjunct faculty position at the University of Alaska Anchorage, and initiated and chairs the Alaska R Users Group. His research focuses on quantifying the influences of systematic error on effect estimates, data integration, and incorporating novel methods for applied surveillance with an emphasis on improving timeliness, efficacy, and utility of data that lead to prevention. Dr. Parrish has developed a novel methodology that integrates both population survey and administrative data sources for studying child maltreatment longitudinally in statewide populations, and is currently replicating these methods in other jurisdictions. So I'm really delighted to welcome both of our speakers. And Matt, may I turn it over to you?
Thanks, Dottie. Let me see if I get this launched. Okay, can everybody see my screen?
Perfectly.
It looks good.
Okay, great. First of all, thanks to Dottie and Meredith for organizing this and for having me and Jared on. We really do appreciate the chance to share this information with you guys. You know, my talk is not so much a data talk as more of a policy talk. There is some data in here, mainly done by Pat Sidmore, who probably a lot of you know on this call. But really, what All Alaska Pediatric Partnership and myself have done over the past 10 years with ACEs is really try and drive some conversations in the state of Alaska, along with lots and lots of other people like Jared and many others, to try and get the state to focus on young children and families with young children as the true infrastructure of the state, and try and put a talk together that was really playing to that, and really tried to get people to see that just like oil and roads and airports, kids and families are just as important to the future of Alaska. And so that's kind of what this talk is about, is really talking about some policy things that have been done around ACEs and the ability to measure ACEs in Alaska and show people that this is really an important topic. And the great thing about ACEs that I'm sure all you guys know, this is a way to present early childhood in such a way that people can really understand it. The great thing about ACEs is everybody can understand the concepts behind ACEs. And so it really speaks loudly to business people, politicians, physicians, public health, everybody. So that's why I really like the ACEs stuff. The other thing that speaks very loudly to people is brain development. And what we're really trying to do with this, with all the stuff that Jared's doing and all the stuff that All Alaska Pediatric Partnership and myself, is we're trying to maximize brain development in kids. And we're trying to make them into their best potential. And so one of the things that I've talked about, and this is a bit of a shortened down talk since we only have 15 minutes, is really try and talk about how to do that, how to give kids and families the tools they need to raise kids to their best potential. And this slide speaks very loudly to people because this shows what happens when you don't do that. And even kids who are not undergoing extreme neglects can still have big changes in the way their brain develops. And amazingly enough, like the business people from ConocoPhillips get this. They really understand brain development and they love the slides on brain development. So I always lead with this slide because it's such an exciting topic for them. But just a quick thing, so we're talking about ACEs today, and we're talking a little bit about how ACEs can affect everything. So here's the 10 ACEs from the original study out of San Diego with the collaboration between the CDC and the local providers down there with Kaiser. And this is kind of what ACEs have been shown to do. If you look through the literature, they affect every organ system. So if you have a child who's exposed to bad things happening to them, one of those 10 things, it affects their anger control when they're older. It affects their sleep. It affects headaches, drug use, smoking. Essentially, every organ system is affected, especially things around mental health. And we'll be talking about some of the programs we've really use the ACEs conversation to develop around mental health services here in Alaska here in a few slides. But this also speaks loudly to people, because when you have people with heart disease and asthma and diabetes, and I see all these folks in my practice as older kids, it's rare that I have a kid who comes into my practice with a headache that's not related to trauma. They never have brain tumors. That's the one thing you worry about from a medical standpoint, but they always have something happening at school, something happening at home that's causing their headaches. So if you can think about trauma in a way that affects medical diagnoses, all of a sudden you're in a very different place on how you treat those kids and the families that have the kids. So here's a little bit of data. This is from Pat Sidmore over at the state of Alaska, and basically it shows that Alaska has ACEs like everywhere else does. This is Alaska data compared to 10 states that do similar ways to collect their ACEs data, and you can see that for the most part we're about the same or maybe a little bit higher in most of these areas. And this is from the epicenter over at A&MC. We have our own epicenter, and they use state of Alaska data from the BRFA study to tease out Alaska Native specific ACEs data. And you can see that in Alaska Native populations, we have lots of ACEs too. So I don't show this to say anything disparaging or anything wrong. There's nothing wrong with different populations in the state. This just shows there's lots of opportunity for people to make big effects in the health of all Alaskans in the future if we can lower our ACEs score over time by building programs to do that. So those, everybody kind of likes bar graphs and charts and stuff like that, but when you want to really make an impact on people who don't think about bar graphs and charts, you put it in terms of people. And this is a chart that was done by Pat again, looking at how to present ACEs in a way that really speaks to a large number of people. And by actually making these little figures of little kids, that speaks very loudly to people, and it makes it more personal, and it makes it in a way that they can understand it better. At least that's what we found, or I found. And so this is Alaska ACEs in the general population. We have, half the kids have 0, which is fantastic, and a few less have 1, and very few have 4 or more. That's where you really get into risk factors for bad things happening as adult and older kids, is when you get 3 to 4 or more ACEs. So the problem with that is it's a big population. It's really hard to build programs for every person in the state. So what we wanted to do was think about how to focus on specific populations that were the highest risk. And so when you look at people who are experiencing low income, so these are folks on WIC or folks on Medicaid, all of a sudden the ACEs scores change a lot. We have essentially no kids with 0. Everybody's got at least 1, and lots of kids have 4+. So if you really want to focus on a population to make a big difference in the future of Alaska health, focus on kids who are experiencing low income, because you're going to have a much bigger bang for your buck than if you just do the general population. And if you really want to have a big effect, focus on kids who are experiencing domestic violence. When they witness this, and Jared will be talking more about this in his talk, I'm sure. When you witness domestic violence, you have essentially every kid has 4+. And very few kids have 1. Domestic violence is one of the ACEs, so you have to have a kid that has 1. And then most of the kids are experiencing multiple ACEs. And what that means is ACEs travel in packs. They don't just travel in singles. And so oftentimes, if kids experiencing one, if you look hard enough, they've got 2 or 3 others happening at the same time. So we really want to focus on the high-risk populations and build programs that really address those high-risk populations. We'll be talking more about that in a couple slides. The other time, so this was done by the executive director for the All-Alaska Pediatric Partnership, along with some other collaborators, and they looked at when ACEs happen. And half the ACEs that a kid experiences in their life occur before the 3rd birthday. And so what that means is these kids, if you focus on early childhood, families with young kids, that's the biggest bang for your buck, because again, those kids are the ones who are experiencing most of the ACEs. So under 3 are where we really should be, in my opinion, we should really be focusing a lot of our resources. So this is a little bit more data from Burfus and Pat. I like to talk in terms of money, because a lot of people think in terms of money and grants and, you know, how do we support programs that are doing this? And my argument is, if we don't support programs that do this, we're just going to be shelling out a ton of cash later. So anybody who has 4 or more ACEs compared to 0 ACEs is 50% more likely to be unemployed when they're adults, 275% more likely to be unable to work at all, or almost 100% more likely to earn less than $20,000 annually. So big numbers, big data. The cool thing about ACEs too is, you know, you're never looking at like 1 or 2% changes in things. If you've got lots of ACEs, you're looking at least 50%, if not 100% to 200% changes in things if you can get those ACE numbers down. So it's a great way to be able to measure big effects on health of population, as well as employment numbers and, you know, everything that affects the population. This is another way to look at it. This is population attributable risk. If you've got, if we were able to eliminate ACEs from Alaska, we'd knock off 30% of the asthmatics. All of a sudden they wouldn't have asthma anymore, and 46% wouldn't have COPD, and 60% wouldn't have frequent mental distress. These, again, huge numbers and big health outcomes. You know, one of the things the state is very interested in is trying to decrease Medicaid enrollment, because that's a very expensive part of the state. So if you could eliminate ACEs from the population, 40% of the adult Medicaid enrollment would go down as well. And these are huge numbers. It's really hard to eliminate ACEs. But this graph shows that if you could eliminate just 1/2 of if you could take the population of Alaska's ACE scores down by 1/2 point. So half the people in Alaska say they experience 1 less ACE tomorrow than they experience today. We start to look just like these other 2 states. So if you then look at these 6 outcomes, obesity, Medicaid recipient smoking, and remember, there's hundreds of outcomes. It's not just these 6. Alaska saves $90 million annually. So we don't have to eliminate ACEs from the state of Alaska to really make a big difference in costs for all the folks who are experiencing ACEs. All you have to do is take it down by 1/2 point, which is not easily done, but much easier than eliminating ACEs. And if you can eliminate 1/2 point here, a couple of years later, eliminate another 1/2 point, all by giving people the support that they need to really raise their kids in a much healthier environment, all of a sudden we're saving all sorts of money and making our population healthy at the same time, which is kind of a cool combination. Just some more data real quick looking at this. So if you were to take our score for Alaska down by 1/2 point, you'd eliminate 5,500 people who didn't graduate college. 5,500 people would graduate college all of a sudden. We'd eliminate 2,000 people off the unemployment line. You would take our depression numbers down by almost 10,000 people. You'd eliminate 10,000 people who were hungry and didn't eat because they didn't have any food. You know, these, again, huge numbers. We remember, for the folks who aren't from Alaska necessarily, we only have, we have less than 1 million people in the state. So when you take 10,000 people off the hunger rolls, that's a big percentage of our state. So very, very exciting data if you can, just take that down by 1/2 point. So, just a couple things on what we're doing at South Central Foundation and Alaska Native Medical Center. The first step in any way to try and help people with ACEs and try and eliminate ACEs is try to identify people who are experiencing this or at high risk of these. This is one of the things that we have embedded behavioral health in all of our clinics. And so if you come to a family medicine clinic, for like a well child visit or a well adult visit, the first person you see is the person who checks you into the room, get your blood pressure, but the second person you see is a behavioral health consultant. And what they do is they do screening questions, and they look for alcohol abuse, they look for development in kids, but they also are screening for trauma and things that could be happening at home that could affect people in a negative way. And so these are some of the questions that we ask at ANMC to try and get to these ACEs, try to get to some ACEs in people. We don't do screeners. There's tons of ACEs screeners out there. We find that just checking boxes on a piece of paper doesn't work very well with the folks that use our clinics. And so we initiate a conversation. And so these are 4 questions that really try and get to some of the ACEs to get to trauma happening at home. And so asking things like what stressful happened to your child since the last time I saw you, that gets to some of the abuse questions. Has it affected your kid's behavior? Because if you had something stressful happen to your kid, but you had really great parents or a great adult around that kid and the kid's behavior didn't change at all, that makes you feel better that the kid is handling that the family's handling it. Maybe they don't need as many services. If the kid's behavior is completely changed, they're not sleeping, they're failing out of school, they're exhibiting violent behavior. All those things mean that the kid needs to get into services quickly, as well as the rest of the family, to get them the support they need to get through that situation. What have you done that you enjoy doing with your child since the last time I saw you? That kind of gets to the neglect questions. And then one of the questions that I like is, give me 3 words that describe your child to you. If those 3 words are not very flattering to the kid, that makes me think that maybe we need to explore that a little bit with the family. Okay, so if your screening's positive, you have to get the kids into family. First, you have to assess them for safety and all that kind of stuff. But I wanted to talk a little bit about one of the programs that's been developed over here, a couple of the programs that have been developed to really address kids who are experiencing stress. The Alaska Child Trauma Center is a great one run by Josh Arvidsson. We'll talk more about that in a slide or two. And then Help Me Grow Alaska is something that we did at All Alaska Pediatric Partnership. And basically what this does is it's a 1-800 number that families can call into to access services. We assign a care coordinator to the family, and they make sure that the family gets the paperwork filled out, make sure that they link to the services that they need, they follow up with the family. And a lot of families who are experiencing trauma are not well equipped to really get into programs because they're experiencing trauma. They're trying to do their everyday living, and trying to fill out a bunch of paperwork to get into different services is not high on their priority list. So we help them with that through Help Me Grow. We also do developmental screening for kids to make sure the kids are developing okay. So this is kind of a cool program. We just took this statewide last year. We got a big grant from Primera Blue Cross to take this statewide because they believe that this will decrease their insurance costs for families who are able to access Help Me Grow. So a very cool program. This is the Child Trauma Center. So what they do is, if you have a kid who experienced trauma and their behavior changed and the family's not sure what to do about it, they do something called the ARC framework. And this is a world-class child trauma center that's right here in Anchorage. And what they do is they teach resiliency to kids and resiliency to families, and they teach them how to self-regulate. And that's really what families need to know. If they're experiencing trauma, how do you get through that trauma in a healthy way? And that's what Josh's group does over at the Child Trauma Center. And it's just a fantastic resource right here in the state. As we move forward in the state of Alaska, what we're really trying to develop is foundations of healthy development. We want healthy relationships. We want a great environment to raise kids. We want healthy nutrition, all these kind of things. So this is kind of what people are thinking about as we are moving forward in the state to really develop a healthy next generation of Alaskans. So here's some systems changes that we've done. One of the first ones we did is we looked at, let me just move my chart over here just a little bit. We looked at changing laws. And so so SB 105 came out in 2018, where we actually incorporated early adversity, toxic stress, childhood trauma into basically any law that we try and develop. And so we have to consider, if a law comes out, we have to consider its effect on these things. And this is now part of the law of the land up here in Alaska. It's a sign of how much things have changed here since 10 years ago, when nobody had actually heard of ACEs. Now it's actually incorporated into the state. Oops. Strengthening families, another fantastic thing that the state of Alaska has done. This builds resilience, it builds self-regulation, and it's incorporated into many different parts of the state of Alaska, both in the education and health and social services. And so whole parts of the organization of state government now has strengthening families embedded within it. And really it's a way to try and build resilience for families and try and get these departments to focus on the importance of early childhood and families with young children. Here's something that just came out. So Alaska's Comprehensive Integrated Mental Health Plan from 2020 to 2024. So just brand new this year. And goal number 1, focus on early childhood, where programs serving young children promote resiliency, prevent and address trauma, and provide access to early intervention. So, we've got 9 different goals, but the first goal is all preventative. It's all trying to change everything for the future so that we actually, maybe goal 9 doesn't have to be addressed very much, because early childhood was so successful in the next generations of Alaskans that our workforce needs, our workforce and data and funding, all those kind of things are less important because everybody's in a much healthier place. We talked about that. Here's some objectives from this. We're even starting to focus on how in Alaska Native areas, so this is from the Aleutian Pribilof Islands Association, how do we incorporate traditional diet, traditional practices, dance, all those kind of things. They've all been, cultural activities have all been shown to improve resilience and improve self-regulation in kids and adults that are practicing them. So here's something that Head Start did, and they decided to incorporate traditional diet into the Head Start programs in the Aleutian Pribilofs. What does that do? So that teaches kids their traditional diet, it teaches traditional foods. We have elders and adults who are bringing traditional foods and interacting with the kids in the Head Start program to teach them about seal and fish and whale and all these different foods that the kids are now experiencing. It was one of the greatest pain in the neck to try and get Head Start to allow this traditional food to come into their program, but it has been hugely successful out there for bringing communities together in such a way around a very traditional diet. And that can't do anything but good things for those kids in the future as they interact with their elders and adults in their area. So, to wrap up, we're building an agenda for families in the state, and we've got lots of people working on this, including the 2 of us here today, but tons and tons of other people are doing stuff about this every day. And just to highlight some of their stuff, we're universal screening for social determinants of health. That's being talked about at the state level. Medicaid is now bought into all this stuff, and they're supporting through the 1115 waiver. That is looking at trying to improve behavioral health services, not just for adults, but it's really focusing on behavioral health services for kids and trying to support that and get people reimbursed for providing behavioral health services for kids so that we can expand that service for all children throughout the state. Looking at early education, we've got Senate Bill 6, which basically tried to bring universal pre-K school to 4-year-olds all throughout the state. So the legislature recognizes this and sees how important it is. Working on paid parental leave, employment support for parents. We've got programs all throughout the state like Children's Lunchbox and Food Bank of Alaska trying to provide nutrition services for families. There's a couple of folks down in Juneau looking to transform their schools into a trauma-informed school to really try and build an amazing project so that kids don't get kicked out of school anymore. They're supported in school, and they can get through traumatic experiences with the help of their schools, which is fantastic. And then there's some cool stuff around early childhood systems development right now. We've developed an early childhood environmental scan that looked at all the programs throughout the entire state of Alaska that affect kids under the age of 8. And we're trying to build a new governance structure for early childhood in Alaska so we can really maximize the use of our dollars as well as go after additional dollars from an organized governance structure so that we can really affect early childhood in the best way that we can up here in Alaska. And just to give you an example from South Central Foundation, we have something called Indigenous Project Launch, where we're changing our whole healthcare system to try and focus on pregnancy and the first couple of years after birth so that we really set families up for great things to happen in the future. So lots of stuff happening. And basically, we're trying to develop intensive intervention and support for families at high risk of experiencing toxic stress so the next generation is much more healthy. and looks a lot like this family. Kids really are the infrastructure for Alaska. There's nothing more important for our future. And that's a bunch of kids who have rheumatoid arthritis. And we built a camp for them because a lot of these kids are from villages. They didn't know anybody else in the country or state had rheumatoid arthritis. They're all on Facebook together now. And that's just a very small example of how you can build resilience just by bringing a bunch of people together who have like minds and really want to get their kids healthier. So very cool. It's a great time to be in Alaska around this. Jared's got some amazing data coming up that we're going to be using extensively to try and drive some of these conversations. And I'm super excited to hear him talk. So thank you for having me. I really appreciate it. And that's my contact information.
Matt, thank you so very much. Can we hold the questions until after Jared's presentation? Then maybe we can discuss at that point. That's okay.
Yep.
Jared? Go ahead.
Just say that if anyone does have a question, you can, and you don't want to forget it, you can type it in the chat box and we'll get to it after the next presentation here.
That would be perfect. Jared, take it away.
All right. Let me move my camera over here. I always love following Matt. He always gives such a great perspective with how it's actually affecting people that they're working with and serving. And I'm just going to give a really brief overview of the Alcan Link project and some of the data that is informative to this topic related to ACEs. Alcan Link stands for the Alaska Longitudinal Child Abuse and Neglect Linkage Project. And it was really one of these ideas that came about inverting the academic model, bringing a rigorous academic approach to the health department to inform program and practice first, and then publication second. And so that was the impetus behind it, so that we could have some strong data to be looking at some of these causal inferences or these strong associations that we see through simple cross tabulations, to be able to take a little bit deeper dive into the data. I got to use the arrow, right? That's right. And so we, a few years ago, the Title V MCH block grant really started promoting this idea of taking a life course perspective and developing programs and practices that can be thinking about, if we intervene early on, how we can shift and change people's trajectories. And when we think about the life course perspective, there's a lot of different research and models out there, but it really boils down to there's assets and deficits that can either promote health or destroy health and lead us to non-optimized trajectories. And when those things occur, really impact that overall trajectory. So timing matters when we do our interventions and how we place them. But everyone here likely knows too that although the life course perspective traditionally thinks about life course from birth to death, it actually incorporates your generations of life before you, your ancestors. So it actually is more intergenerational when we think about life course. And so the Alcan Link data can hit on that life course perspective, thinking about this intergenerational transmission of trauma or transmission of health practices. So just real quickly, what this project is that it's a mixed design approach. So we're taking epidemiologic survey data and administrative data that is representative of our statewide population, and we're integrating that and linking those together and following our population every year over time. And so we've turned a cross-sectional study, which is the Pregnancy Risk Assessment Monitoring System survey, which is a survey that's CDC funded and conducted in nearly all 50 states. And we've taken that cross-sectional survey and turned it into a longitudinal study, which gives us a lot more power when we talk about looking at someone's life course. With respect to Alcan Link, we take the PRAM survey. Like I said, it samples in Alaska about 1 out of every 6 live births that occur in our state and is representative of that birth population. And for Alcan Link, it's the 2009, 10, 11 births. We can expand that if we need to for certain specific studies. But the core linkages that occur annually are with our permanent fund dividend database. And that's a really nice asset we have in Alaska because it's effectively an annual census of our population. And because we're linking to our administrative records like Child Protective Services, what we call our Office of Children's Services, and our education records, if someone moves out of state, they're no longer able to be detected in that record system. And so the permanent fin dividend database allows us to censor our population or remove them from continued follow-up and ensure that we're calculating the most appropriate effect estimates over time. So this is our core data linkage that we do. We also are benefited by the Cub survey, which is a 3-year follow-up survey to PRAMs. And so we have 2 touch points for survey, and then we have multiple touch points for administrative records so that we can get a really rich data set and maximize the data that we have in the state. What we immediately found when we looked at measuring the cumulative incidence, so the individual's risk of experiencing an event before this is before their 9th birthday, what we found is that in our state, approximately 1 out of every 3 kids born in our state during this time window will have a report to Child Protective Services. 1 out of every 4 will have one screened in. 1 out of every 8 will have it substantiated by our child welfare agency. And 1 out of every 16 kids born in our state will experience some form of removal. It might be a short-term or a long-term removal from their home. Immediately when we first saw these results, what I actually did is I actually threw out my whole study and did it again because I thought they were wrong. Because I had been only exposed to prevalence estimates or annual estimates based on prevalence data, and so these numbers just seem shocking. But now that we know and we have a lot more evidence from the BRFSS data that Pat's been able to conceptualize and put out that a lot of adults experience ACEs during their childhood, these numbers make a lot more sense. And so we wanted to start looking at what are the differences between kids that experience a report of harm or screening or substantiation. Now from public health, we often use report of harm as our end measure because someone somewhere noticed something that they felt obliged to call in. And when we've seen in the literature, children that experience a report are much more similar to kids that have substantiated abuse or removals in their home. And so from a population-based public health perspective, that first report is a really good indicator for us that, wow, there's something going on in the home. So we use that as our indicator often. So Matt already covered what ACEs are, but this picture here I think is really nice because Robert Wood Johnson Foundation grouped the ACEs into different buckets. We have the abuse bucket, then the neglect bucket, and the household dysfunction bucket. And when I look at those buckets, I see 2 different types of buckets. I see abuse and neglect as something that the child themselves experience, and household dysfunction as the environment with which that child's being reared. And when I look at those 2 buckets and how these ACEs interact and cluster together, we really got interested in looking at how household dysfunction results in either ACEs or abuse and neglect. And so what we did is we broke those apart. We took the household dysfunction and we looked at the household dysfunction that was occurring before the kid was even born. And so we were able to get that information from the PRAM survey. And we mapped the questions from the original ACEs related to household dysfunction onto the questions that were available. And we measured the ACE score, or the household dysfunction score is what we called it. And then we looked at this pre-birth household dysfunction and how it predicted abuse and neglect as measured as reports to child welfare before their 8th birthday. And as you can imagine, we saw the same stepwise association. We found that pre-birth household dysfunction, the number of pre-birth household dysfunction, is strongly related to the probability that a kid will experience a report to Child Protective Services before their 8th birthday. And so if you look at the little bar chart here, if a child is born to a mom who reports 0 household dysfunctions during that pre-birth window, a little over 20% will experience a report to child welfare. But if a child is born to a mom who reports 3 or more, over 80% of those kids will be reported to child welfare before their 8th birthday. So now this gives us an indication that household dysfunction that exists prior to a kid being born has an effect on abuse and neglect. We wanted to look at it related to ACE score now. So we looked at household dysfunction that was pre-birth household dysfunction, and then we created an ACE score at the child of age 3. So we used those same pre-birth household dysfunction, but we also added in a financial stressor. And we did that because of the research by David Finkelhor that he's put out on expanding ACEs to improve the predictability and association with negative outcomes. So we used an expanded ACE score here. And so we calculated the household dysfunction score, and then we calculated a childhood ACE score at age 3 using the CUBS data, which is that 3-year follow-up survey, plus the administrative data from our Child Protective Services data. And it's not shocking what we found. What we found is that relative to children born to moms that had zero household dysfunction, zero pre-birth household dysfunction, there was a stepwise association with an average higher ACE score. So basically, children who are born to mom with more pre-birth household dysfunction, they're more likely to have more ACEs in their life. So when we talk about or think about preventing ACE scores or ACEs, we're actually talking about improving that home environment with which that child's born. If you think back to the slide that Matt showed, where I think it was almost 26% of kids experience their ACEs in their first year of life, that's because the household that they're being born into has a lot of dysfunction. So some kids are born with an immediate ACE score. And so when we think about prevention, we've got to be thinking about upstream, about creating that really good environment. And this association with increased ACE score, it doesn't care about race, it doesn't care about education, and it doesn't care about age. Even after we adjust for those same associations are found. And so this transcends populations. And we've seen that, that association in ACE literature for a variety of outcomes. Now, we next wanted to break this out, the household dysfunction out a little bit. And so we looked at the pre-birth household dysfunction, and then we looked at household dysfunction experienced during childhood. And we wanted to compare whether those predicted contact with child welfare. And what we found is we found whether you had pre-birth household dysfunction or childhood dysfunction, we saw the same sort of stepwise association, albeit the effect estimates are a little bit stronger in childhood, but the same stepwise relationship exists. And so what this led us to was like, well, what happens if we were able to change the number of dysfunctions that are household dysfunctions from that pre-birth window to the childhood window? And what we found is that if we stratify our groups into two groups, a low risk group and a higher risk group. And so if you had pre-birth household dysfunction of one or fewer reported, and we looked at in childhood, if that decreased, if just the overall number of household dysfunctions decreased, what was the effect? And if that number increased, what was the effect? And what we found among our low risk group, if we increase the number of household dysfunctions from pre-birth to childhood, the risk of contact with child welfare increases by 2.4. So it substantially increases the risk of contact with child welfare. On the flip side, among our high risk group, so if you have two or more pre-birth household dysfunctions reported, if we decrease that number, it significantly reduces the risk that a child will have contact with child welfare. This provides us some evidence that if we actually do interventions and strengthen that home environment among our high risk group, we can actually have an effect on reducing the need for our child welfare system. It also shows that among our low risk group, we have to maintain some sort of maintenance, and we have to be involved in them, because if they get infused with those household dysfunctions, it's going to increase that risk. And so this was really striking, because now, while this seems pretty intuitive, we have some direct evidence that shows we actually can see an effect on this that we were able to observe. Now, Matt said something really interesting, that these ACEs travel in packs and pairs. But there's also something interesting too between our low risk group and our high risk group when we think about children that have multiple stressors versus children that only have 0 to 1. When we look at our low risk group, the stressors that they're experiencing are a lot more benign when we think about it with respect to intervention. We think about it with respect to multiple effects occurring simultaneously. Whereas among our high risk group, that's where we see a lot more of the influence of drugs, depression, job loss, homelessness, jail, divorce, and IPV. So when we think about preventing ACEs and dropping it by 1, we're really talking about complex systems and dynamics. And so we're going to have to be thinking about addressing them from multiple angles to deal with multiple contexts. I've read a lot of literature lately about ACEs prevention, and a lot of the ACEs prevention focuses on preventing one of the individual ACE components of it. But we also need to be thinking about all the components that are there. And this slide shows how they cluster together within the data that we have. So the dark blue line is measured from the pre-birth, and then the light blue line is measured during childhood. And it's the height of the bar is the average number of coexisting stressors. If a mom reported homelessness, there's a lot of coexisting stressors. And whether this occurred during the pre-birth window or during the childhood window, the accumulation of ACEs or the clustering of ACEs seems to be pretty hold through that window. And so when we're talking about interventions, we're talking about preventing ACEs. Like Matt said, and I echo that, we're really talking about supporting environments and families to optimize health and development for that individual child who's brought into it. Further, there's a researcher who utilized these data out of the University of North Carolina, and this is a pretty busy slide, and I apologize, but I just want you to look real quickly. What we've done is that often I get asked about, well, what about the protective factors? What about the protective factors? And what she did was conduct a latent class analysis where we look at groups of people and what clusters they fall into, looking at risk and protective factors. And we stratified by our indigenous and our non-indigenous populations because we know that there's going to be some variation in that. And what we found among both groups is there were two types of clustering groups that come together, a generally low risk group and a higher risk group. But what was critical with this is that even among the high risk group, there are protective components where these risk factors can be addressed through. And so when we think about reducing our risk factors, if we can address them through existing protective components in that household or that family, then we might have a lot more of an effect on that. And also there's some differentiation between our populations. So we can't just take a one size fits all with addressing our protective factors or what risk factors we need to be dealing with. And what's important for us to remember is that a lot of our families are living in a high protection or in a good, healthy environment, and it's about 70% that can promote health and development. And especially among our indigenous population, the cluster that was interesting is that it was low SES but high protection. So just because you're poor doesn't mean you're doomed. And I think that's an important message because oftentimes we put that low SES as a factor that stands alone of itself. But if you're low SES with strong protections, that's not going to doom you as a child being reared in that environment. And so I think it's important for us to recognize these things so it controls some of the language we use so we don't perpetuate potential stereotypes and biases. So just to wrap up, what these data are suggesting with respect to adverse childhood experiences is that prevention has to occur along a continuum, that one person's intervention is another person's prevention, especially when we think about that with respect to the intergenerational transmission of this. That we need to be supporting pregnant women and parents to build environments that maximize learning and development. And all these factors that we have found are what that means by supporting parents. We have to address these things directly. We also need to be thinking about it not only about when the mom's pregnant, but before that time, and providing medically accurate, age-appropriate, comprehensive health education. We have to teach them what healthy relationships look like, what they should be involved with, and how to start addressing with self-regulation at that time point. I don't have kids, but every parent that I've talked to, when you add a kid into an environment, it adds stress, not reduces stress. They're kind of stressful creatures. And so if you have a stressful environment that's already occurring and you add the stressor into it, it can expand that stress. So if they have self-regulation skills, that can help deal with some of that stress. And then finally, preventing ACEs, when we talk about that, really should begin before birth. When we think about when they occur and the frequency of when they're occurring and how they've developed them, our prevention, again, is along a continuum. So that's what I wanted to share with you guys today with some of the work that we have coming out. And I think Matt and I are happy to answer any questions.
Jared, thank you very much. That was wonderful from both of you. Can we open it up now? I know that Meredith has another call in a very little bit of time. Meredith, I'm going to allow you to set the limit on that, but are there any questions or comments? Please unmute yourself and feel free to ask. Okay, since no one is saying anything, I'd like to ask you both about, on the one hand, Matt, you made the comment, or you made a point of talking about trauma-informed care, both in the medical setting in terms of how you asked about trauma. And I thought it was very interesting and wondered how you got to the screening questions that you got to, and if you could talk about trauma-informed care and a trauma-informed place in schools. And then, Jared, if you could maybe also talk about what the Alaska State Government and Department of Health is doing in terms of trauma-informed activities or activities to meet the needs of Alaska populations around this. Gentlemen?
Go ahead, Jared.
Yeah, so I mean, Matt had a really nice slide on there that I think people should review it, looking like what the state and a lot of agencies are working together to try to address adverse child experiences and being trauma or trauma informed. Our Department of Education Early Development, they're doing a lot of great work there. And on the slide there, we actually, working with the commissioner, we have Department of Education data linked in now to Alcan link. And so we have data that measures third grade reading scores. We can predict to those scores, and we can show the correlation between kids that perform poorly in school have higher ACE scores, and they're the same kids that are receiving a lot of our child welfare services and a lot of healthcare services. And it's providing us some strength for to take it to our legislative body to say, hey, we need to be allowing these systems to work better together to address these things up front, so that when kids come to school, they're prepared to learn, and when they're living in our environments, they're acting in a healthy way. And so that's one way. These data have been directly used and were really instrumental in the 1115 demonstration waiver project for determining what factors were going to be billable services. And we're utilizing these data to try to refine that over time. Right now, I'm working on a little predictive model where we can put it into an app where, and while Matt, they're not using a specific screener, but it would be more question-based. Because one thing that we have a problem with ACEs is that we use that ACEs as a screening tool and a diagnostic tool. And that's a problem in the medical world. We need to recognize that screening is screening, and then you have to do diagnostics after that. And so I'm developing a predictive model where we can screen, and then it will identify what are the most poignant issues that need to be addressed, and then diagnostics can be done on that to determine whether it's affecting health and development and what protective factors might be in place. And so that's how this is being used right now to try to move things along to help with being trauma informed. But I honestly think one of the biggest things is just all the work that Matt's group has done and a lot of other groups to advocate for it in the state government, because then we see that trickle down into the individual agencies that we're operating in.
And, you know, that was a great summary. I think the only thing I might add is kind of highlighting on some of the silos that that Jared was talking about. The school and the education and the healthcare systems are two huge silos with lots of barriers between lots of barriers that make it very hard to work between the two. And so we actually have an interesting grant out right now where we are going to try and break some of those barriers down to bring the services directly to the kids. And we're specifically looking at like development issues in kids where we will use our development clinic to take referrals directly from teachers and directly from people in the schools, and then we will provide developmental services back in the school environment to try and bring services to where kids are. And I think that is a great untapped resource of medicine. It's really hard for parents to bring kids into clinics, even if you're in a village, and walking in the cold to get to a village clinic can be very tough. But if we can bring services to the schools and break down some of those barriers, and really have the schools focus on becoming trauma informed, have our healthcare system become trauma informed, and then work together to share data and to share services for the kids. I think that's a huge area where I hope to be working on in short order to try and break down at least that silo. And that's one of the things Help Me Grow does too. Is Help Me Grow really is built to break down silos between all these different services and families. So I think that is our next big project is trying to eliminate barriers between families and getting to what the help they need.
Thank you both very much. You've really been inspiring, and as people drop off, I've been getting messages about how terrific the talk is. I wish we had a longer time. Meredith, did you have anything to say?
Well, thank you, everyone. The meeting is recorded and there will be notes posted. The slides are already up. I shared the link with everyone. If you have questions, you can comment there and we can get those questions addressed. And I guess the last thing I'll say is stay tuned for next month's meeting, as we'll be having a discussion on the development of the next 5-year plan and what would be useful in terms of health research goals in that plan.
And it would be really great to be able to have some input from you, Jared, and you, Matt, on this particular performance objective, because it remains a huge problem and a huge issue to address. Thank you both very much.
Thanks for organizing. Good to see you, Jared.
You're welcome. Good to see everyone.
Thank you.